Hepatic encephalopathy occurs because the cirrhotic liver becomes increasingly unable to perform its normal job of metabolizing ammonia and other toxins. We talked about the clinical manifestations and diagnosis of hepatic encephalopathy in the prior video, which include altered mental status, asterixis, other signs of neuromuscular impairment, and elevated serum ammonia. The initial management of acute hepatic encephalopathy in patients with cirrhosis involves two steps. The first step is identification and correction of the underlying cause. So let's draw in a Greek dude chiseling at the underlying base of the statue. Remember that the liver is unable to process toxic proteins in the blood. As such, a few of the common precipitants of hepatic encephalopathy involve increasing the amount of proteins and toxins heading to the brain. GI bleeding, for example, causes more protein to land in the GI tract, which is absorbed into the blood. Infection, including SBP and UTIs, are some of the most important causes of increased bacterial proteins and toxins entering the blood. Renal failure, too, decreases the body's ability to excrete ammonia and toxins. How about constipation? More time for gut bacteria to send proteins and toxins into the blood. States of hypoxia are also associated with hepatic encephalopathy. Hence the dead hypoxic head of Medusa up there. Not a good look. States of hypovolemia, caused by diuretics, vomiting, or excessive diarrhea, for example, can also precipitate hepatic encephalopathy. Low intravascular volume leads to a metabolic alkalosis with associated hypokalemia. And the brain doesn't like hypokalemia. Not to mention low perfusion. Treatment includes volume resuscitation and repletion of potassium. Once you've addressed the underlying cause, the second step in the treatment of hepatic encephalopathy is initiation of measures to lower blood ammonia concentrations. Lactulose is the drug of choice for lowering ammonia concentrations. Lactulose is metabolized by gut bacteria into acidic metabolites. In the resulting acidic environment of the gut, potentially toxic ammonia is converted to ammonium and excreted by the body. For patients who have not improved within 48 hours or who cannot take lactulose, rifaximin is another treatment option. It reduces ammonia production by eliminating ammonia-producing colonic bacteria. Together, treatment of the underlying cause and reduction of serum ammonia concentrations will result in improvement in the patient's mental status. All right, that's it for hepatic encephalopathy. On to portal vein thrombosis. Portal vein thrombosis involves the blockage or narrowing of the portal vein by a blood clot. It's a relatively common complication of cirrhosis and thought to be related to unbalanced hemostasis and slowing of portal flow due to portal hypertension. Portal vein thrombosis can be acute or chronic. The clinical presentation of portal vein thrombosis is variable. While it's often clinically silent, acute thrombosis may present with symptoms that include abdominal pain, distension, nausea, and fever. So-called septic portal vein thrombosis can even occur, presenting with spiking fevers, chills, and a painful liver. If the mesenteric veins become involved, mesenteric ischemia or infarction can occur, manifesting as abdominal pain, ileus, hematochezia, peritoneal signs, or lactic acidosis. Check out our Dia de los Muertos sketches over in the GI unit for more ischemic fun. In contrast, variceal bleeding is the most common presenting symptom of chronic portal vein thrombosis. That's because thrombosis in the portal system only further increases portal hypertension, sending that pressure instead to the portal cable shunts, which, over time, turn to varices at risk of bleeding. So we've brought in a few extra variceal monsters bleeding at the mouth. As we covered in the last sketch, recall that variceal bleeding can present as hematemesis, hematochezia, or melena. Patients with chronic portal vein thrombosis may also present with the typical signs of portal hypertension, such as splenomegaly and ascites. Though it's important to remember that portal vein thrombosis is not necessarily the cause of deterioration and may be superimposed on progressively worsening cirrhosis. Portal vein thrombosis can be diagnosed with a Doppler ultrasound, though it's often diagnosed incidentally on ultrasound or CT imaging being performed for a different reason, such as diagnosis or monitoring of hepatocellular carcinoma. Patients with chronic portal vein thrombosis should be screened for esophageal varices. Varices, if found, are usually treated in the standard manner. The management of portal vein thrombosis, PVT, is exactly what you'd expect: anticoagulation. Start with low molecular weight heparin to achieve rapid anticoagulation, and then bridge to an oral agent when the patient's condition has stabilized. Because these patients are at risk of variceal bleeding, The decision to anticoagulate must be made on a case-by-case basis. Anticoagulation is typically reserved for patients at risk of rethrombosis. Varices must be properly managed and treated, either with beta blockers or endoscopic procedure, before anticoagulation is started. All right, on to our next complication of advanced cirrhosis, hepatorenal syndrome. As described in the previous sketch, portal hypertension causes splanchnic pooling of blood. Not only that, the cirrhotic liver has a hard time metabolizing all the toxins entering the blood through the GI tract, including bacterial toxins. This causes increased nitric oxide production by vascular endothelial cells. Systemic vasodilation follows, especially of the splanchnic vessels, which we symbolized with these dilated abdominal snakes here. With all that blood pooling in the splanchnic circulation, the kidneys become hypoperfused, and creatinine rises. The onset of hepatorenal syndrome is usually insidious, though it can be precipitated by acute insults, such as spontaneous bacterial peritonitis and upper GI bleeding. With all that pooling and vasodilation, how about we get that pressure back up? For patients who are unlikely to have a quick recovery, there are a few therapies used to improve renal perfusion. This buff dude grabbing the snake, constricting it, if you will, represents vasoconstrictors, which can help constrict the splanchnic vasculature and raise the mean arterial pressure. Critically ill patients may be given norepinephrine, while more stable patients can be given midodrine plus octreotide. Midodrine is a systemic vasoconstrictor, while octreotide inhibits endogenous vasodilator release. Therapy is usually continued for 2 weeks. In combination with pressors, albumin is administered to increase oncotic pressure, thereby increasing the intravascular volume for better kidney perfusion. Albumin is administered for at least 2 days. As with most of the complications we mentioned, the ideal therapy for hepatorenal syndrome is improvement of liver function from treatment of the primary liver disease. If this is not possible, a TIPS procedure or liver transplantation may be the best option. Moving on from the kidneys to the lungs. Patients with long-standing cirrhosis and portal hypertension can develop hepatopulmonary syndrome, or HPS. The mechanism is complex, but involves abnormal vasodilation of the pulmonary vasculature. The result is intrapulmonary shunting, leading to VQ mismatch and hypoxemia. Patients present with dyspnea. The definitive therapy is liver transplant, typically for patients with an arterial partial pressure of oxygen less than 60 millimeters of mercury. And finally, the last complication of cirrhosis to discuss, hepatic hydrothorax. Ascites is sometimes associated with the transudative pleural effusion, thought to occur due to small defects in the diaphragm. These defects permit peritoneal fluid to pass into the pleural space. The passage of fluid is promoted by the negative intrathoracic pressure generated during inspiration. The effusion typically manifests in the right hemithorax, but it can be left-sided or bilateral. Hepatic hydrothorax is suspected in a patient with cirrhosis and a pleural effusion, usually greater than 500 milliliters, who has no other reason to have a pleural effusion. In other words, there's no known cardiac, pulmonary, or pleural disease. Patients with hepatic hydrothorax generally present with typical pleural effusion symptoms that include dyspnea, non-productive cough, pleuritic chest pain, and hypoxemia. The diagnosis is confirmed with diagnostic thoracentesis, which will show evidence of a transudate. Check out our pleural effusion DDX sketch for all the sopping wet details. Treatment of hepatic hydrothorax is similar to the treatment of ascites: salt restriction, diuretics, and abstinence from alcohol. Definitive therapy is, of course, liver transplantation. Speaking of, over next to this liver plant, let's talk about transplant. To become eligible for a liver transplant, it's not enough to simply have cirrhosis. Remember the MELD sodium score? As discussed earlier, it plays a vital role in the allocation of liver transplants. Patients with cirrhosis are typically candidates for liver transplantation once their MELD sodium score is greater than or equal to 15. The transplantation evaluation is typically started once a patient's MELD sodium score is greater than 10. This permits the patient to meet the transplantation team prior to the development of end-stage liver disease and ensure adequate time for the patient to complete the pre-transplantation evaluation. Patients may also qualify for liver transplantation if they have a complication or condition that qualifies for one of the standard MELD exceptions that we mentioned earlier in the video. Lastly, Patients with conditions that are related to their liver disease that don't qualify for the standard MELD exception points can be considered for liver transplantation if their medical providers believe that the MELD sodium score does not adequately reflect the true severity of their disease. Some of these complications include refractory ascites, refractory hepatic encephalopathy, and refractory variceal hemorrhage. All right, sum up time. We assess the severity of disease with the MELD sodium score. It uses bilirubin, creatinine, sodium, and INR to predict 3-month survival. It's primarily used to prioritize patients on the waitlist for liver transplantation. There are also a few conditions dubbed standard MELD exceptions which can bump up the MELD score. The Child-Pugh classification is used to stratify patients into 3 classes of cirrhosis, each correlating with a range of 1 and 2 year survival times. Treat cirrhosis by treating the underlying cause. That means, when applicable, abstinence from alcohol, antivirals for Hep B and Hep C, and weight loss. In all patients, it's important to vaccinate against Hep A and Hep B, avoid hepatotoxic meds, and remember that other meds may need to be adjusted. Esophageal varices are a complication of portal hypertension that can lead to life-threatening bleeding. Most patients with cirrhosis will get screening with upper endoscopy. Patients with medium and large varices will be given primary prophylaxis to decrease bleeding risk. This includes beta blockers and endoscopic ligation. Patients with new ascites should receive an ultrasound to confirm. A paracentesis should be performed for newly diagnosed ascites, or for patients with pre-existing ascites who are hospitalized, or, thirdly, for patients with ascites who are deteriorating clinically. On paracentesis, expect clear yellow fluid and a SAG greater than or equal to 1.1. Treat ascites with sodium restriction, diuretics such as spironolactone and furosemide, and, if tense ascites, large volume paracentesis. SBP is a bacterial infection of ascites fluid not caused by a surgically treatable source. Typically, it's from gut bacteria such as E. coli and Klebsiella. It can present with diffuse abdominal pain, altered mental status, and diarrhea. These patients typically present with fever, and it can progress to septic shock, so watch out. Get a paracentesis. The diagnostic criteria include a positive ascites fluid culture and a PMN count over 250. Differentiate it from secondary peritonitis, which can be caused by bowel perf or intra-abdominal abscess. While awaiting cultures, empiric therapy usually includes a third-generation cephalosporin. Prophylactic antibiotics should be given to patients with a history of SBP or cirrhosis with GI bleeding. Hepatic encephalopathy is treated by treating the underlying cause, and there are numerous. Lactulose and rifaximin are used to reduce the ammonia being generated by gut bacteria. Portal vein thrombosis presents acutely with abdominal pain, distension, nausea, and fever. It can even be septic with a painful liver and spiking fever and chills. Mesenteric ischemia can complicate the situation as well. Chronic portal vein thrombosis presents with variceal bleeding and other signs of portal hypertension. Portal vein thrombosis can be seen with Doppler ultrasound or other imaging. Patients should be screened for varices as well. If varices are treated appropriately, some patients will be put on anticoagulation. Hepatorenal syndrome is usually insidious in onset, but can be precipitated by an acute stressor, such as a GI bleed or SBP. It's treated with vasoconstrictors and albumin infusion to get blood back to those kidneys. Hepatopulmonary syndrome presents as a triad of liver disease, hypoxemia, and intrapulmonary shunting caused by pulmonary vasodilation. Treat severe cases with O2 and eventually liver transplant. Hepatic hydrothorax is suspected in patients with cirrhosis and a pleural effusion with no other obvious etiology. They present with dyspnea, cough, chest pain, and hypoxemia. Thoracentesis will show a transudate. And finally, liver transplant is indicated when a patient has a MELD score greater than or equal to 15, or they may qualify with certain MELD exceptions. All right, that's it. Next up, the bathhouse, where we'll jump into that ascites fluid, wait around a little, and get all saggy. It's more fun than